In your late 40s, the steady stream of hormones you've relied on for decades drops off a cliff, causing your biological foundation to rapidly shift. Hormone replacement therapy is a targeted medical treatment designed to fill that gap. It supplements the estrogen and progesterone your body has stopped producing in adequate amounts. While hot flashes are the most visible sign, the deeper impact includes sleep disturbances, unpredictable mood instability, and a pervasive cognitive fog that disrupts your daily life. This chart illustrates a hidden, rapid threat. As estrogen and progesterone drop, they intersect with an accelerated downward curve, bone density mass. In the first 5 years after menopause, up to 20% of your bone mass can vanish. You want your quality of life back, but years of conflicting headlines about cancer and blood clots often lead to decision paralysis. The variety of choices complicates the decision further. Between pills, patches, topical gels, and creams, figuring out the right starting point is a significant challenge. HRT safety is determined by two specific variables: the date you start and the specific formulation that matches your anatomy. Making a safe decision requires moving past generic advice to build a personalized biological roadmap. This diagram shows the first mandatory step of the HRT Matrix, assessing your anatomical baseline. We start with a simple question: do you currently have a uterus? If you have had a hysterectomy, we follow the no path down to estrogen-only HRT. Estrogen alone safely provides symptom relief without uterine cancer risk. But if you have an intact uterus, we follow the yes path to combined HRT, adding progesterone to your regimen. Estrogen alone causes the uterine lining to thicken excessively. Progesterone protects that lining from cancer, though this combination carries a slightly increased breast cancer risk after about 5 years of use. Once you know the baseline formulation, you have to choose how those hormones are sourced, leading to the debate between bioidentical and synthetic options. Bioidentical hormones are lab-created formulations that share the exact chemical structure of the natural hormones your body produces. While bioidentical formulations offer peace of mind, they require the same medical monitoring and dosage adjustments as synthetic versions. Your biology dictates the foundational formulation you must take. From there, you must decide how to deliver it into your body. The next layer of the matrix is the entry point. The most common starting method is the daily oral tablet. This diagram tracks the biological journey of oral HRT. When you swallow a pill, it must pass through the liver, a process called first-pass metabolism, before it can enter the bloodstream. Pills are convenient and often covered by insurance, but that liver processing increases the risk of blood clots. To avoid that risk, you can use systemic alternatives like transdermal patches and topical gels. Here, a cross-section of skin shows how transdermal methods work. The patch delivers the hormone molecules directly into the bloodstream, bypassing the liver. By avoiding the liver, patches and gels lower the risk of clots and strokes. However, they require daily management and can cause local skin irritation. While pills and patches offer body-wide relief, vaginal preparations deliver localized, low-dose estrogen. These are effective for treating local discomfort and urinary symptoms, but they do not address hot flashes or bone loss. For women seeking to minimize clotting risks while getting systemic symptom relief, transdermal patches or gels are the safest path forward. The delivery method is only part of the matrix. The timing of your first dose is just as critical. This timeline shows the green window of opportunity: menopause onset up to 10 years later, or age 60. Starting here reduces osteoporotic fractures by 50% and stabilizes cardiovascular health. Starting HRT over 10 years after menopause pushes you into the red danger zone. Late initiation might still relieve night sweats, but it increases cardiovascular risk. For this reason, medical providers generally reject starting systemic HRT this late. Committing to this timeline also means planning for monthly costs that can range from $10 to over $200, along with annual medical screenings. Time is a deciding factor. Delaying the decision past the 10-year mark can turn HRT from a protective measure into a cardiovascular liability. There are strict medical boundaries to consider. Hormone replacement therapy is not a safe option for every viewer. This checklist shows the absolute contraindications. If you have known hormone-sensitive cancers, active liver disease, or a history of blood clots and strokes, you must avoid HRT. For those who cannot use hormones, highly effective non-hormonal alternatives provide significant symptom relief. Non-hormonal medications like SSRIs, gabapentin, or Veozah modify neurological pathways in the brain to manage symptoms without introducing hormones. These alternatives can reduce hot flashes by up to 60% without the risks associated with estrogen or progesterone. However, these drugs do not provide the bone density preservation and cardiovascular protection found in estrogen therapy. While alternatives can manage immediate symptoms, remember that only HRT builds and actively protects the physical foundation of the body. The ideal HRT candidate is a woman under the age of 60, experiencing symptoms that disrupt her quality of life, who wants long-term bone protection. For these candidates, the standard approach is to use the lowest effective hormone dose for the shortest necessary duration. Transdermal methods, like patches or gels, are the preferred choice to minimize clot risks while achieving full body relief. To move forward, document your uterus status and cardiovascular history to prepare for a consultation with a healthcare provider. By treating HRT as a precise biological calculation, you can safely and confidently reclaim your health and vitality.